Now let's begin by understanding what plaques actually are. Atherosclerotic plaques are not just cholesterol deposits. They are complex structures made up of cholesterol, immune cells, fibrous tissue, and often calcium, especially as the plaque matures, embedded within the artery wall. But here is the crucial part. Not all plaques are created equal. There are two main types: stable plaques and unstable or vulnerable plaques. For stable plaques, these have a thick fibrous cap, a smaller lipid core, and minimal inflammation. They're like a well-healed scar, present but unlikely to cause any trouble. However, the unstable or vulnerable plaques, these have a thin fibrous cap, a large soft lipid core, and are surrounded by active inflammation, making them fragile and dangerous. Think of an unstable plaque like an inflamed skin pimple. It may not look that big, but underneath it's swollen, irritated, and filled with inflammatory material. That thin outer layer, the fibrous cap, is like the fragile skin covering the pimple. If pressure builds or the surface weakens, it ruptures. And when that happens inside an artery, the body rushes to seal the rupture with a clot, which can block blood flow entirely, triggering a heart attack or sudden death. This is why degree of blockage isn't everything. In fact, research shows that most heart attacks occur at sites with less than 50% narrowing. According to a peer-reviewed study by Dr. Peter Libby, a professor of cardiovascular medicine in Harvard School, highlighted in the Journal of Circulation in 2005, he said coronary artery disease was previously considered a cholesterol storage disease. We currently view atherosclerosis as an inflammatory disorder. Think about this. This information was already being discussed back in 2005. Yet here we are in 2025 and the dominant narrative still insists that LDL is the main culprit and must be driven down at all costs. But the truth, which perfectly aligns with the mission of this channel, is clear. The real drivers of cardiovascular disease are insulin resistance and chronic inflammation, not cholesterol. Dr. Peter Libby highlighted also in this study, he said, we now recognize that disruption of plaques that may not produce critical stenosis causes many acute coronary syndromes, which is exactly what we mentioned in this video intro. You can have a non-critical stenosis or non-significant stenosis like 40 or 50%, and if it ruptures, it can still lead to an acute coronary syndrome. In this same study, Dr. Peter Libby said that recent results have established the multiplicity of high-risk plaques and the widespread nature of inflammation in patients prone to develop ACS. This perfectly underscores that heart disease isn't just about one bad plaque. It's often a whole network of vulnerable inflamed plaques waiting to rupture. Well, no wonder cardiovascular events are the leading cause of death globally. Many people who suffered sudden cardiac death were previously told they had non-severe blockages. That's because a small unstable plaque can be far more dangerous than a large stable one. So the real question isn't how blocked are your arteries, it's how stable are your plaques. Move, move, move! Hi, I'm Dr. Haitham Faraj, a certified cardiologist. If you want to learn more about what makes plaques stable or unstable and whether lifestyle intervention can help heal them, check out my full video over here. Sorry, I mean here.